These are the pearls I learned from the stalwarts sitting on the dais, Dr. Osher and many others. So keep in mind, and good luck when you have this kind of cases next time. Thank you so very much.
Thank you, Abhay. Such a wonderful teaching on the posterior cataract. And the videos were so clear, so transparent to see every bit of fibers also. And your teaching has been, I think, it has gone to everybody to how to perform effective phaco in these cases of posterior polar without the capsular opening or a capsular opening or intraop difficulties. Beautifully shown. Thank you again. I would like to invite now Dr. Partha Biswas, the chairman of our scientific committee, AIOS, to give us his own tricks, tips. You know, another difficult situation of doing phaco in post-refractive surgery patients. Not only for doing phaco, for getting a good outcomes in terms of a good calculation of IOL power and the effective counseling which Abhay talked about, not only to the patient, to the relatives also. All yours, Dr. Partha.
Thank you very much, sir, for inviting me to this course, a very, very valuable course that you have year after year. And post-refractive surgery phacoemulsification is something that we need to talk about, because though it might be a rare possibility in a crowded OT, but still when this possibility comes, then one has to be absolutely on the toes. So how do we approach a patient of post-refractive surgery phacoemulsification? So what are the challenges? And the unique challenge to the cataract surgeon is because this patient is a demanding patient. He always has been without glasses, and at his presbyopic age might have put on just the reading glasses, and thereby he needs that vision free of glasses even after his cataract surgery. So there are a certain amount of unrealistic expectations, low accuracy of the current biometry formula, which are becoming better and better every day, but nothing is foolproof. And therefore, the refractive surprise is the most important thing, and the traditional formulae lose accuracy because these patients can end up with post-operative hyperopia, and if that happens, then it's a huge difficulty. Post-hyperopic refractive surgery patients can end up with post-operative myopia. So what are the sources of error? And it's the keratometry, which the assumption of the spherocylinder cornea leads to an overestimation of 15 to 25%. So the relation between the anterior and the posterior cornea is altered, and the assumption of the refractive index of 1.3375 actually becomes fallacious. So it's an error in the formula, and thereby, after a myopic KRS, these formula predict false shallow ACD, leading to an anterior ELP, and thus an overestimation of the intraocular lens power, causing the post-operative hyperopic surprise. So the formula which are supposed to be used in these patients, the historical method is a matter of history now because we have better things, and again, which we do not rely upon so much. The ASCRS online formula is freely accessible on the website, which allows the input of the data available with or without the preoperative data. And also the multiple formula that are available to calculate the IOL power, and an average of all the formula is also displayed. So this is, the tomography is also helpful in analyzing the anterior as well as the posterior corneal curvature. And the intraoperative aphakic calculation is one aspect that I need to stress upon, and the simple on-table retinoscopy after extraction of the cataractous lens can be a very, very accurate method of choosing the right lens. The intraoperative aphakic aberrometry may also be used, but it is expensive. Limitations include alteration of IOP, patient fixation, pressure of the speculum. The ALP prediction is still not accurate. But again, I will stress, the simple on-table retinoscopy is something that I trust even today by my best optometrist who comes in and does the retinoscopy during the surgery. And I'll suggest that all of us follow this method as a final cross-check, and then that post-operative surprise will not happen. The role of preoperative counseling is even more than what Dr. Abhay Vasavada said for his posterior polar cataracts. Here, the counseling has to be intense, has to be persuasive, has to be elaborate, and has to be done by the surgeon himself. And here, the realistic expectation regarding the spectacle independence must be given. The intraocular lenses may not be, the presbyopia correcting intraocular lenses might not be the right choice for these patients and must be explained in detail. Also, the residual astigmatism. The post-RK phacoemulsification, and here where there are more than 8 incisions, so here the incision that you have to make is a scleral incision, because if it is a corneal incision, these incisions of the RK might open up and then you have a very difficult proposition. The phaco has to be performed with low parameters, and the patient counseling regarding the irregular astigmatism is very important. Here is a case where the RK incision opened up, and these have to be sutured meticulously. Let's talk about this mystery case to drive home a very important point. This lady presented to us with a 2-grade cataract, and we planned phaco plus IOL. All biometric calculations were done, and then she comes back without her husband to tell that some 19 years ago, she had some surgery done to remove her glasses. So the pentacam then was done, and it became a very, very important tool, and we could see that there was an evidence of refractive, laser refractive surgery that was done. So we evaluated, and we took on the pentacam readings, the flattest of the K readings, and calculated. We calculated, but on the table retinoscopy provides us the final biometry or the final IL power calculation, and we implanted 15. We implanted a 15 diopter lens. The ASCRS online calculator gave us a 12 diopter, but we did implant the 15 diopter, and this was the post-operative result. So with this post-operative result, had we implanted the 12 diopter lens, we would have definitely be on the error. So again, to stress upon the fact that the on-table retinoscopy is very important. The post-ICL phacoemulsification, the ICL is a very thin structure, and there has to be no evidence of removing the biometry, any deviation from the biometric calculation that you would do for a normal patient. Am I the last speaker, sir? Can I? Okay, I'll just take 2 minutes then. So this is a case which I just wanted to show you how complicated it can be. And here, this is a case which went on after laser refractive surgery. The patient had a retina detachment. The retina detachment was resolved by the retina surgeon. But in 3 months' time, the patient lost vision. And the vision was lost because of this intumescent cataract. This was a patient who had undergone a phakic an ICL, and after the ICL, the retina detachment occurred. The post-operative to the retina detachment, this was the intumescent cataract. So the removal of the ICL is being done, which is not so difficult, and a hand-over-hand technique is being applied for this patient. The ICL comes out quite smoothly in such patients, but it has to be done very well. So we put in trypan blue for this patient, but this is an intumescent cataract, and you would have noted that there was some synechia in this cataract. So I'm going to have trouble here, and as I try and do off the capsular axis, the capsular axis runs out. And it runs out not in one place, but in 2 places it runs out. So we have an open bag here, and the pupil is crowding. And why did this intumescent cataract occur in the first place? There was a lens touch by my retina colleague, and that is the reason why it had occurred. You can see the plaque sitting over there. So we placed in a 3-piece lens in this patient, put it in. We do not know whether it went into the sulcus or half into the sulcus and half into the bag. But then what we had to do is to do an opening in that plaque. And it's very important to limit the opening in the plaque, and we did it with the MVR blade going in, and then with the vitrector carving out a small area through which the visual axis could be assessed. And so after this, the patient, of course, did not gain 6/6 vision, but had a good vision of about 6/24 and N12. So just to show that these situations might arise, not every day, but it can happen, and when it does happen, then things have to be taken in the course of the light of that particular patient, with all the importance given to the refractive analysis and the workup, as well as the surgical technique and the pre and the post-operative counseling. Thank you very much for your patient hearing.
Thank you very much, Dr. Partha, for highlighting all the aspects of doing cataract surgery, post-refractive surgery, let it be the old generation radial keratotomies or ICLs or laser surgeries, where it is, demand from not only from our side, from patient and parties to have an exceptionally better vision than any other group of cases, because they have undergone refractive procedure in their younger days. And cataract surgery, I believe, is surgery where you can get a absolutely fantastic vision after removal of cataract. We had a terrific session covering all the aspects of a difficult situation as well as a simple answers for these cases. I would take, we